When you want to get a little bit of a tug on the lateral jawline over here, okay, what you do is the following. You can use a product. I use Voluma a lot for this. I use what I call Volift, which you guys will get, which is Volure, and I use Refine. And she particularly asked me for the Galderma products for her particular case. The other patients are going with the Allergan products because we wanted to make sure that we got an even display or setup. Let me give it to me on, that's the Refine. You can give it to me on a 30 gauge needle. It comes with a 30 gauge. That's it right there. Perfect. And I'll take a little cleanser with that. So how I used to do this was I would go ahead and build a strut over here and here and hope that the volume that I created would actually give her a little bit of a lift. But what I'm going to do now, okay, is I'm going to try to literally pin her up over here just a little bit. So we're going to get, yeah, cleaner. We're going to try that. Why not? Yeah, why not? I started doing this about a month ago where I changed the way that I was doing the injections over here. I mean, it's like Einstein said. He said, if you keep on doing the same thing over and over and over again and expect a different result, that's the definition of insanity. Okay? If you keep on doing the same thing over and say, yeah, I'll keep doing this, but I'm going to get better results. No, you got to change it up sometimes. Thank you very much. It's primed? Yes. Beautiful. Thank you. So we're going to turn her over here. I have pillows and everything to deal with, but we're going to be fine. What I do is I look for the angle of the jaw over here, as you can see. Okay? I retract the skin. Okay? I have my needle ready, and I let the skin fall back into my needle. Do you see that? Okay? And then I lift the tissue like this with the needle. Sometimes the needle comes out a little bent. And I'll put in 0.05, not even 0.1, but 0.05 of product. Just a slow injection like that. Okay? And I'll do it again. You can use Radiesse for this as well, absolutely, if you want to contour a jaw because it has a very high G prime and it can absolutely contour this area, there's no question. But what I'm trying to do now is I'm trying to use the cohesivity of the product. That's why, or the stickiness of the product. It's why I love to use Voluma or Ultra or Ultra Plus because they're very cohesive for this type of thing. And this product, Refine, has some stickiness to it as well. And as I said, we're doing as the patient requested and what she would like to have product-wise. I guess everybody wants to try the new stuff, but that's okay.
How does that work, Arthur?
I don't know. To be honest with you, I really don't know. And let's see if it's going to work. Okay? That would be kind of interesting. I usually put in about 0.4. What I think is happening is that there's actually, there's a ton of little ligaments over here that the masseteric ligaments, the ones that are over the masseter muscle over here, and there are little ligaments coming out of the parotid. The origin of the rhizorius muscle is coming off parotid fascia right over here, and it's going to insert into the modiolus over here too. So there's a lot of things that are happening in that area. I'm staying above parotid fascia. If I was to touch parotid fascia with my needle, she would let me know. It is really not a very pleasant thing. So I'm just doing that, and not allowed to bruise her, so I'll keep my finger here, and I'll just click and fire up over here. And right now, I'm at about I haven't gotten to 0.6 yet. I told you I like to do it in about 0.4. Okay? There. Does that give you an indication? If I had to guess, I would say about 3 millimeters, 2 or 3 millimeters. And I'm putting in 0.05, not 0.1 per injection, because I don't want to cause lumpy bumpiness. What I'm trying to do is I'm trying to almost reset those ligaments. It's kind of like thinking almost like, and I don't believe this, but some people think that you can inject behind a ligament and it acts like straightening your knee. You put the product in behind and the ligament sort of flips up. I don't know why I just started to do this way. I just thought about it one day. That's the last injection that we're going to give her over here. And I'm going to take a little bit of arnica gel. That's a 0.05. And all you guys can do this. Just flatten your needle out and do a very shallow injection, but not into the dermis. You're going to hold this and cap it. You're going to give me, you can put it on the back of this one right over here so that I don't contaminate it. Perfect. And I'm going to take a little bit of this and we're going to work this up a little bit. And we're going to make very nice. Okay, there we go. And we're going to see what we did to the jawline on this side now. I checked her beforehand. She was she was symmetrically, sorry to say this, jowled on both sides, okay? So we're going to see if we've had an effect. Watch, the other side will look better, and then we'll just have to melt everything out, right? No. Okay. Here we go. What I'm doing with my fingers, by the way, is I'm not doing really much molding. It's like Ken says, I'm doing blending, and more importantly, I'm running my fingers over her face to see if there's any lumps or bumps that I left behind. Let's get you to sit up a little bit. Let's get them to pan out the camera a little bit over here. And we're going to try to straighten your face. It's a little hard. Let me just adjust your face for you, okay? Mm-hmm. Oh, yeah, you can see the difference. Let me tilt you a bit this way. There. Look at the jawline difference on the two sides. Do you see that? I do. Does anybody else see it, or am I just the only one? Okay. I see it really well. Just relax. You can look into the monitor and you can see. Look at the curve of the jaw over here, and look at what we have sitting over here, okay? And she was... You like that?
Beautiful.
Okay. So what we've done is we've bolstered that area. I don't know, it's almost like you're sitting and gluing it. And what I do with this now is that on those patients that I've done facelifts on, that come back after 6-7 years and say, I want a secondary tightening because they have just a little bit of jowling over there. I used to send them for energy devices. I'd send them for Thermage. I'd send them for Althera, and they'd get a little bit of an improvement. But what I do now is I just, right away in my office, I say, I'll fix that for you. And I just put in a half a syringe, not even a half, 0.4 is what I found works, just perfectly. 0.4 in on this side, 0.4 in on that side. Let me see if we can get you to look at this camera over here. Sorry about that. Okay. So let's put your head back over here, and let's look at the camera, or sit you up. And see, the camera's a little bit above you, so there's the camera over here, which is a little bit angled. And then you can see, I'm going to adjust your head. Just relax, you're fighting me. So I'm going to try to adjust. I know, it's hard. I'm going to show you one other thing, okay? Okay. When you start to bolster the area over here, give me a smile. Where you see cheek lines, give me a smile. Look at the difference. Okay? Look at her smile now. Give me a smile. Okay? Look at the way she's pulling on this side, and you're seeing she's looking at herself in the monitor. Yeah. Look at I'm seeing your back molars over here, and look at the smile on the opposite side. Do you see the difference? Okay? And that's all about myomodulation, as we call it, but what it really is I just added a red guy on one side rather than or added the blue guy on one side instead of taking the red guy off on the other side. So I'll do that with these series of injections over here. She looks really good on this side. I did her cheek while we were waiting. I just did a little bit of her cheek, but it did nothing to the jawline. We sat her up and we looked at it to make sure. But I did a little bit of her cheek on this side. She's got a narrow face. I don't want to go ahead and blow her out. Okay, but she just looks much more refreshed on this side. Okay? And what we're doing now is that I do also, in patients who really have a big grin, I will put the cannula in over here, and I will run the product. She actually wants something in her upper lip, so I'm going to do that. We're going to run the product here and here, which is really going to give her a little more of a boost over here. I mean, if I have to do a little jowl area over here, I'm just going to put in a little teeny bit of product over here. Look how good that's going to look. Wow. Okay. We should do that. Come sit back. Okay. So it's a great little trick, guys. Try it. I've only been doing it. I have a total now probably of about maybe, I started doing it like 2-3 weeks ago. I have a total of maybe about 6-7 patients. In fact, I had my nurse sit the patient up halfway through, and we took pictures to see if we're really having an effect right away. And we took pictures an hour later to make sure that it wasn't a situation of lidocaine somehow causing the problem, and the stuff was still staying up there like that. Those patients have come back at 2 weeks, and they're still excited about their results. I'm not exactly sure why it's happening. I think I have to use a cohesive product. I would suggest that you use any of the Vycross products over here, most probably Voluma, because you need a little more robustness, or you use a product like Refine. Okay? And if you have Belotero Volume would work perfectly here too. Okay? But not a stiffy product, not a product that's too stiff. That, if you're using Radiesse, I don't think you would get that, because with Radiesse you're going to get the sharper definition of a jawline, which is perfect, but not the cohesivity that you're getting with this. Okay? When I use Voluma over there, it depends on the skin quality. So what if it was a person that had a thick skin envelope? And a lot of, would I blend it or not? No. What about somebody who was coming in that had, she's got average skin, but somebody who was 60 years old, 70 years old, and you almost can read a newspaper through their skin? Thank you. There you go. Or you could use Ultra or Ultra Plus, so something that's a little more spreading. But if you have the syringe of Voluma in your hand, I know the company doesn't like to hear that, but if you have the syringe of Voluma in your hand, then what I do is I start to bastardize it because I want to finish the syringe and use the syringe on the patient. But otherwise, plan in advance. Okay, if I had to plan her whole face over here, I would want to do some nasolabial fold on her. Ultra's perfect for that. I can use it in this area as well. So that's what I think of. I need a syringe to do that. I need a syringe of, let's say, of Ultra. I need a syringe of Define. I kind of figure out what I need. And then I sort of say, okay, in my head, I got to do 2 or 3 syringes. She's prepared to pay for 2. I push her for the extra cost of the, she doesn't know it's the cost. It's what I'm doing in my head. She says, I only can afford $1,200. I say, well, I have this idea that I can do $1,400 worth of beauty on you. And she'll say, well, how many syringes are you going to use? And I say, whatever it takes. I learned that from Kent. He said, I never even look. They just keep passing me the syringes and I inject until I'm happy. And there's no sticker price shock like that because you've already told the patient what it's going to cost. And if you use an extra bit of a syringe or an extra syringe or 2, so instead of making $1,600 an hour, you made $1,400 that hour, you'll make it up on the next patient, not intentionally, but it averages out. Correct?
Correct.
Yeah. So that's it. Can I have the same product? What did we use over here? We used Lift over here, and then we used Refine at the bottom. So put the Refine on a cannula now, a 27 gauge cannula.
27 gauge?
Yeah, the 27, the one that I have, that's the shorter one. I used to charge by the unit, okay? I used to charge by the unit because patients were calling and saying, how much does he charge per unit? And I would tell my nurses to say, as much as he can get. Patients don't come in and say, give me 1.2 cc's or give me 13 units of toxin or give me 35 units of Dysport. They don't say that. They say, make me beautiful. Take away the lines that are bothering me. Recontour my jaw. So they're asking you for a result, not for the product. So what I did was I started saying, okay, for Glabella, I'm charging $350 for a Glabella to be done, period. Some patients need 30 units. Thank you. Some patients need 30 units. Some patients need 20 units. I don't look at what I need. I kind of assess in advance, and I don't think about it that way. And I'll average it out. Okay, if it's a male, I'll tell the male, sorry, it's $400 for a Glabella, because on the average, that's what it is. And then if you do it that way, there's like no sticker price shock. So when it comes to the multi-syringe patient, how I charge in my practice is I have two levels. I'll charge $2,900 or $3,900. That's the way the market will bear it in Montreal, $29 or $39. What does $2,900 get you? If it's a patient like this who's coming in that I have to do a full face, is she a 7 syringe patient? No. Is she a 6 syringe patient? No. Is she a 5 syringe patient? No. I've already used 1 syringe. I used 0.4 over here, and I've put about 0.4 into her cheek. So she's already almost a syringe. To finish off this side, maybe I need another half a syringe. She's probably going to be somewhere between 3 and 4 syringes. I have that in my mind, and I'm going to do toxin on her. So I'm saying to myself, you are a $2,900 beautification. If I have a patient who come in who looks like me, it's completely deflated, I'm charging myself $3,900, and I might use 5 syringes or 4, and I might use 100 units of Botox or maybe 300 units of Dysport. But patient already knows the price, no sticker price shock. And I'll tell you what else, it takes the pressure off you when they come back for a touch-up. They've already paid the full thing. And that's when the little BD2s come out and I touch them up and they're very happy with it. It's the patients who get the full face treatments that don't complain in your practice. It's the ones that you chase a line and they pay $200 that come back and say, I don't see the result. Well, hello. No kidding. So what's how we do this over here? Kent has a different approach a little bit, but I'm going after the upper face. I've really been struggling with this pillow over here, but we're going to be fine. No, don't worry. You have to be comfortable. Don't worry about me. Can I have a cleanser again, please? I have one right here. So we're going to use the cleanser. I'm going in this area right about over here. So you're going to feel a little stick, Ellen. Bing. Okay. And I'm spinning. Okay. I'm probably sitting over the artery of modiolus because if you look at the facial artery is at the level of about the lateral commissure and about 1.5 centimeters outside. If you want to find it when you're doing surgery, it's 1.5 centimeters outside and deep, but I'm staying superficial. We didn't talk about the anatomy of the upper lip, and I'm going to talk about that now just for a second while this thing is, don't let her leave your office, by the way, like this. It's not a good thing to do. I always said I never let a patient leave the office like this, not because you're worried about the way they look, but because every 16-year-old in the city is going to want one. It's going to become the new fad. Wow, did you see that girl with the needle sticking out of her face? Okay. So I'm going to spread this. She'll be good for me and bleed probably, but let's see. Yeah, there's a little drop of blood. I'm holding it again. You see the way I'm holding it like a dart? That's the way I would suggest that you do it. I'm looking for my little compress. Can I have a compress that has a little bit of cleanser on it, please? Thank you. Not too much. And I'll make sure that it's okay, I'll hold that. I'm just going to make sure that I put a little pressure there and that I have some cleanser there too. I just don't want to, this is super clean, but it's not a sterile technique. If my surgical colleagues would see what we're doing over here, they'd scream. Because this isn't, but I'm trying not to touch the cannula part that goes into the patient. I'm sort of sitting on the skin over here, but I'm just making sure that we don't do it. Now what I do is the following. I then switch my hand to this injection position. I flatten out the angle like Ken told you. And what I do is I start the injection as I'm advancing. And I have a very light amount of pressure, so I'm going to put the plunger down into my palm.
Thinner eminence.
That's right. And I'm slowly starting, and you're going to watch a little pop. And I got to tell you that you know how painful it is to inject lips. And Ellen is very stoic, but she'll tell us the truth, that if I had to ask you how painful that was, what is it out of 10?
10. No, just kidding. I don't know, 1 maybe?
1 maybe. That's what I usually get, a 1 to 2. And you can see that where I am right now is in the lip, and that's the part that the patient really doesn't like, and I'm right there now. And what I do is I start, just like Ken says, you start this little subcision with gentle pressure on it, and I go back and forth, okay? If I was going after this with toxin, I would have it already added into here. That's the way I do it, but you can certainly treat her afterwards. And I'm going back and forth with gentle pressure, and it allows me to coat the whole thing. So what I am doing is I am putting in a layer of product between the skin and the muscle. There's a little bit of fat there, but not a whole bunch. And I got to tell you, what happens as we get older is that the fat content of our upper lip actually increases, not decreases. But the muscle content decreases. And you'll feel a little pop every now and then. And if I really wanted to, my depth over here is just subdermal, right? And if I wanted to, I could chase it right to her philtral column. Look. Okay? And then usually my last injection, as I go back and forth, how you doing? My last injection, you're going to see a little pop over here, is right where the white roll of the lip would be. And I allow the product to come back out as I'm injecting. And to be honest with you, if I wanted to volumize her lip, look where I am. I'm in the vermilion over here as well. It's a great access point. I love this access point because I'm going to show you what I do now. I've used very little amount of product. There's a little pop. Ellen, I'm going to go underneath your lip over here right now, okay? Are you good? Mm-hmm. It's a weird feeling. I'm going to almost withdraw my cannula completely. I'm going to change its direction. I'm now going over here, and there's always this just funny feeling pop that occurs right over here. You're going to feel a little pop. Boom, there it is. And now I'm into what would be considered the ergotrid of the lower lip, but there's no such word for it, as we said. And now I'm structuring the lower lip. 2 things that women have above their necks that men don't have. This triangle over here, which I've now treated, but on the other side, if Kent goes ahead and squeezes and shows you on the other side, there's going to be a triangle here that you can see it. You see it right there?
See it here.
You can see it. I've lost that on this side because I've buttressed across it already. So women have that triangle, men don't. I thought it was the way that women talked that was the reason that they went ahead and got, not because they talked so much, don't get me wrong. Because of the way they pursed their lips when they were speaking. But you know how I sort of disproved, because I've never seen it in men. So I started to look in the gay population in my practice of men. I started to look. Let me know if I'm bothering you and I'll just get this done.
You're just annoying her is all.
I'm good at that. Okay. I'm coating the whole thing here. I'm using here refined, but I could use, this is going to be a little pop here. There's
straight up in a 27 gauge cannula, 1.5 inches, 37 millimeter cannula.
What other product would you use there?
You tell me. What else could you use?
Ultra.
Fobel is too thin. Ultra would work. What else? Ultra Plus if what? Skin was thicker, and what else? If the grin was really, really wide and I needed something with a little more robustness to it to try to prevent her from smiling out so far, I would use Ultra Plus. So I use Refine, Ultra, Ultra Plus, and when you get the equivalent of the Allergan product, which is going to be Volure, you'll be able to use that also in this area. The idea is it's not a volumizing thing, it's a structural thing that you're doing. So you don't need a lot of product.
You're contouring, shaping, and creating.
Sit you up here a little bit.
What about blended Voluma?
Yeah, you can do that, I guess, too. That's
Why?
A little bit
Why
of
would you blend Voluma when you've got other products that are straight up?
Here we go. Okay. Twist my head like that.
I wouldn't
Perfect.
blend Voluma.
So look what happened now to this area that people have been asking me, how do you treat that? You know those little drapes that patients complain about? That's exactly how I treat it. Give me a little smile. Boom. That's very nice. Isn't that nice? Yeah. It looks really good, and I think you need a little support down over here, and that'll be it. But give me a little smile. What do you see there? Give me a smile on this side. There we go. Okay? See, she's trying to pull her lips back, but she can't now because there's more resistance to the tissue over there. This is a great little trick, guys, because patients don't realize it. This is the serendipity that he was talking about. But we have a tendency to grin as we get older. And so this gives us back the natural look. I got to tell you something.
Be careful with your blended products because you want structure and contour and support.
No, it's pure.
And if you blend your products too much, you eliminate that. So blended has a place, but I think you have to be really careful with blending because then you defeat the structure.
The companies are coming up. Can I have let me have the Define with her now, or give me. We actually opened up. No, we had Lift. I'll finish off with Lift over here. So when I'm injecting the lower part of the face over here, I start inferior and work my way up. So I have a couple of questions for you. Again, it's all about depth. What is the anatomy over here? There's superior and inferior. You all right? The superior and inferior labial arteries are coming off the facial artery. They sometimes come off as a common trunk. They sometimes come off individually. But interestingly enough, 80% of the time, the superior labial artery will come off above the commissure, and 60% of the time, the inferior labial artery comes off above the commissure. So you'll actually get the inferior labial artery sometimes starting up over here. It's kind of weird. All right? Those arteries, the superior labial artery is the most tortuous artery in this area, just like its friend, the facial artery. But it's tortuous not in this way, because we're not talking about a spring action this way. We're talking about a spring action this way, right? So it's tortuous like this. It's like a dolphin going in and out of the water. When we dissect it, you can see it that it's in the muscle, it's out of the muscle. It's in the muscle, it's out of the muscle. It keeps doing this like a dolphin going through the water. Here's the kicker. That artery is never more than 4 millimeters deep. It's always 4 millimeters or less deep. And I see people firing in needles over here to do lips, and they're coming in at a steep angle. You're going to hit that artery. And we just saw a case of somebody that was injecting over here. Injuries to the upper lip are too common. So there's two ways to treat an upper lip. You either stay, as Kent was showing us, submucosally, where you're safe, and you can use a cannula or a needle for that. Or, if you're injecting into the body of the muscle because you want to do a lip augmentation, more than an enhancement, you want to give them more volume, you must be in the upper third, meaning the superficial third of the muscle. You can't go in deep. I see people injecting in the posterior aspect over here. That's her artery sitting right there. You can roll it between your fingers. Okay? You can't do that. So the artery is at the level of the vermilion border. If I was to drill a hole straight down over here, I'd hit it, but it's doing this. So when I want to fill a lip that I want to get an augmentation, I have to go halfway between the wet-dry border and the vermilion border. I have to go into this part of the lip, staying inferior or below, okay, the artery, and in the upper third of the muscle. This is what you got to think. So take your time when you do this. You can't do that with a cannula. If you try to drive a cannula into the muscle of the lip, the patient will never come back again. It hurts. Cannulas don't like to stay within muscles, right? So you can use a cannula, as Kent and I have been doing for the submucous area. You can use needles. I go ahead and I flip the skin back, and I let the lip fall onto the needle again. I found that I have not had to block a lip probably now for about 7 years. Okay? So what we're going to do now is we're going to inject the bottom part of her face. Yeah, that's perfect. The inferior labial artery isn't as tortuous, and it has a tendency to sag below the vermilion border, so it can be located over here. So if I'm injecting for the zone here, the marionette zone, and we're talking about Restylane Lift here. We're continuing with the Restylane products, and then we're going to move into the Allergan products. What I do is I go ahead and I pinch the skin at the same time that I put the needle in. She's in now. Okay? I'm injecting on bone because this is the platform on which everything is going to sit. Nobody can convince me that the lip is supporting the chin. It's the chin that supports the lip. As we age, we lose the volume, and the lip turns down. We're going to put a small bolus on the bone over here. Very gentle, slowly. We're going to release and lift like we usually do.
Right over top of the vessel, so we're going to have to put a little pressure on there.
Okay? And away we go. We're fine. When I get to the next injection point, if you want to try to find the next injection point, this is a little trick that Raj Keela showed me, because I was always saying I inject at half the depth over here, because the way the mandible is curved like this, that if you go down onto bone, I don't like to do that because you're hitting the depressor labii inferioris with your lidocaine. They'll have a funny looking smile for a while. So my injection is half the depth. Look at where it breaks here, and then look at where it breaks here. Okay? At the crosshatch of those two places, I go in halfway. I lift the tissue up a little bit, and I put in another small little bolus. Very slow and very gentle.
How'd you get so smart? That's perfect.
Watching you, my friend. Okay? I'm firing with your half of the brain now, that's why. And then my last injection is usually 3 or 4. I don't want to put product on teeth. I don't want to go deep because I told you the arteries are no more than 4 millimeters deep over here. So my last injection is just under the skin. I'll lift and I'll fill just gently. Small amount.
As you notice, she's got a minefield of vessels here that are kind of all down through here. So
there's a bunch of vessels going through here. Now, if we see injuries to the lips, it's usually the upper lip that takes the heat and not the lower lip. If you inject up over here and the product flows backwards into the facial artery and then flows forward, we usually see the upper lip take the beating, not the lower lip. Why is that? Because there's 2 accessory vessels called the horizontal and vertical labial arteries that are coming across the chin that are going into the lower lip as well. So very often we're probably blocking that inferior labial artery, but we have accessory vessels that are taking up the slack. You don't have that on the upper lip. You only have the one from the opposite side and a little vessel over here called the philtral vessel that's coming off the columellar vessel. So you don't have a lot of support on the upper lip, and that's why you see those wedge injuries that we were talking about. So my typical volume here is 0.1, 0.05, and 0.05. And so my question to you is, when do I stop? Because what I was trying to do on her, there we go, is neutralize the lip. I didn't want to have all this stuff hanging down. And I wanted to decide, am I going to stop when she's neutral? Am I going to stop when she has a slight smile like this? Or am I going to leave her with a slight frown like that? Look how the tissue wants to bounce back now.
You have to be careful you don't get the Joker look as well.
Correct. You can leave a slight smile on a young individual. If a patient's in their 30s or early 40s, if you give them a slight smile, slight, very slight, it's not smirky, it looks appropriate because they're young and they're enjoying life. Makes sense. And I always use this expression. If my wife was walking down the street and she had a perpetual smile on her face, people would think, what the hell is she thinking about? It doesn't look appropriate in the more mature patient because we should be smiling responsively. If somebody tells you something that you're enjoying, you give them a little smile. But to constantly with a little smile on your face, people would think that there's something wrong. So that's how I judge on how much I'm going to do over there. She has good projection of her chin. Look at the difference, what we did in the upper lip. Look at the lines over here. Look at the lines over here. I've released them with the cannula. I've coated underneath the lip. And I really would love to add in a little bit of toxin so that she doesn't purse as much. Let me see a purse. There you go. Okay. Part of that is lidocaine effect, guys. Don't give me credit for everything. But part of that, okay, do you feel a lot of numbness in your lip? Not that much, huh?
Yeah.
A little bit. Yeah, there's only a little bit in the product. Part of that is lidocaine effect, but you'll see this. That's why I do the pictures on my patients. If I want to show animation, I wait an hour or so to make sure the lidocaine effect is out. But part of that is lidocaine. But the whole idea is if we have toxin will keep her like that for about 3 months. And during the healing process, she won't be able to grab the dermis over here. So we're going to do that because she's in New York, I'm in Montreal, and although I love to go visit her every now and then, I want to make sure. Look at this difference in the smile, guys. Did you see that spontaneous smile? Look, I'm seeing her molars on the left side, right? But I'm not seeing them on the right. Isn't that a nice little smile that she has? Isn't that what we call a more natural, more youthful look? Okay? So that's the idea behind it. Let's hold this here for a second. Sure, we'll do it on her just to show you. She's pretty good. She's going from the L to I. Do you see that? She should really be a little more vertical over here. I'll show you the little injection. I'll use the same product with the cleanser over here, please.
Want needle or do you want a cannula?
No, I'm going to use the needle. I'm going to go right down onto the bone over here to see what the story is. She has very little parotid that's in the way because she does have some definition. And what you can do over here, you're going to feel a little stick out, okay? Is you find that little area right over here. It's a vertical injection. Sorry. And I just want to show you that I'm on bone. I can't go any deeper. You must feel bone. I got to change the needle on this, by the way. It's still a Dell needle. So you must feel bone. And then we put in, usually what I put in is about 0.25, but she's rather thin. So I'm going to put in about 0.15. So I'm at 0.1. Oh, don't even need more than that, I don't think. Okay, I'll go 0.1.
You can also use the cannula along here and
right. Especially like Ken pointed out to us, in patients who've had previous rhidectomies, patients who've had previous facelifts, very typically, because of the tension that we put on when we try to get these patients coming across, we put in stitches into the SMAS. We do either a SMASmectomy or we do a SMAS tightening, a plication, or a SMAS flap, and we pull tight over here. Okay? Then we try to drape the skin over the top, but that SMAS, as it pulls tight, is putting tension and pressure on the fat that's there, and they have a tendency to, after a while, to get a little bit of a scooped out look in the preauricular area. And Ken pointed that out beautifully. He talks about the pitcher ear deformity, right? Same thing. And then you can use your cannula and you can treat the patient over here. I was mentioning to a group before, if you're taking down the masseter on a patient who's over 40, 45, they're going to jowl on you because you're taking away volume here. Yeah. You have to replace volume somewhere. You don't want to put it back where you just took it off. Put it right here. Fill it here, and then you won't have that problem.
Sometimes in that gonial angle, I use that needle too, but I use more and more a cannula, a 25 gauge, 1.5 inches, but I bend it. There's one place that I don't do the chubby checker twist. I do in a twirl because I want it bent, and I just thread it along to get the angle of the gonial angle.
Sure.
And inject that along, and that works really, really well. It's just another option.
Head up again? Sorry, sweetheart. Here we go.
And that's where I'll use Define or Voluma.
Yeah. It's right here. This is the vertical ramus of the mandible. This is the horizontal ramus of the mandible. I'm putting it right on the bottom
right
spot.
On the gonial angle.
Right over here where you feel that little bulge. You'll miss that bulge in patients who have parotid hypertrophy because that's where the parotid will come around like a C and it will cover this whole area over here.
Yeah.
I'd like to do one other thing on her, and then we can finish her off screen because it's getting to be late. Look at me straight on, love. Okay. I'd love to see a picture of her when she was younger. Look into the camera. You have it in your phone? Mm-hmm. Great. Just look in straight. That's it. Okay. What I'd love to do is to fill in the infraorbital hollow on her over here. Would you allow me to do that?
Sure.
Oh,
sure.
Yeah. Of course.
Okay. So I'll show you the technique that we do for that. People get a little nervous about this.
Fine.
Cleanser, please. So I'm going to use a very thin product for this. We'll stick, because we're doing resting on her, and we're going to be using Virbela, we're going to use a little bit of silk on her.
Do you want it blended, or do you want it straight up?
I'd like it blended, if you don't mind.
1 to 1/2. We need to blend it.
Okay, why don't you do that? Yeah. And I'll talk about how we do that. You're okay? Okay.
Yes.
What you do is you check the patient's photos when they were younger, because if you're going to create an eyelid that she didn't have when she was younger, she's going to look different. I'm sure that she always had a lot of upper lid that
That's
shows,
the normal sitting.
but not as much. She's digging through your phone now to find all the photos?
My phone's right there. I've pulled it up so you can see.
Okay. So you don't want to create something the patient hasn't had. If a patient has had filtral columns, don't create filtral columns because people will pick up and say, you look different. So if she never had a full upper lid, we don't want to give her a full upper lid, but I can promise you that what happens as we mature, not age, but as we mature, the high point of the upper lid moves from next to the nose to the middle of the eyelid, and it creates what we call an A-frame deformity in the Caucasian. Wow.
It's high school picture.
All right. So if you can focus in on this, you can see in high school, where's all that upper lid that we're looking at now? She's been hollowed out. We see that post-surgery. We see that as patients mature, okay? She didn't have a lot of eyelid. No young person really has a lot of eyelid. They have a lot of fullness in the infrabrow region, and we have to recreate that fullness. So Kent is sort of, here you go. Kent is, what are you doing with a high school picture in your phone? That's cool.
So you wanted me to bring it, so I got it.
See that? Smart. So I get patients to bring in photos to see what they look like before. What we're going to do over here, I'll explain the technique before we do it, and hopefully we'll be able to recreate what we explain. I pick a place that's lateral over here. I like a lateral approach. Vessels are running this way. I want to stay below the orbital rim, but not on the eyelid, and I want to hug the orbital rim. So I pick a place that's halfway between her eyebrow and the bottom of her rim over here, because if I put in a cannula over here, which I'm going to use a 27 gauge, which is a pretty wide gauge for a very thin product, that's why I have to get the plunger into the palm, and I got to squeeze very gently, right? So what I do is I go from here, because if you're cantilevered against this, I'm going to have to struggle and be really awkward to go ahead and to enter the orbit like this, because the bone won't let me. It's a protective way of doing it. And I'm going to coat in this area. I'm going to show you how I advance the cannula. I choose a 27 instead of a 30, because even though a 30 will limit the amount of product that I'm using in because it's smaller, it's a little bit sharper, and I don't want to cause a bruise of the upper lid. There's a bunch of blood, little veins and stuff over here, but we got the two major arteries that are sitting over there, but they're coming out from the bone over here. So if I stay on the inferior surface of the bone, I should be fine. Okay? So we're going to take our little 27 gauge needle. You're doing great. I just have this, I'm just doing a little CPR here on the pillow before we... Here's the cleanser. I'll take a 27 gauge needle, please. Kent is already prepared. Why don't you explain to them what you did?
This is a little more than 1 to 1/2, just a tiny bit.
That's fine. I usually do 1 to 1, so it's not a problem.
It's about 1 to 1.
I just need my needle here first, the 27.
There you go, 27.
The product that I'm using over here is Silk. I want a product that's very thin. My products of choice over here are Volbella and Silk. Okay, and if you have also Bellotero. Bellotero Balance would work well over here too. I usually wet that down also as well. We don't have any Bellotero on the stand over here. I would use that. And we also have Bellotero Soft up north, which is a great product. And just as my colleague was mentioning before, I like to use 50-50 blends over here because you're giving the product the fluid that it's looking for so that there's not a lot of swelling after you inject. The only swelling that you really get after this is related to trauma. Even though I'd love to give her a perfect result, I'm not going to not give her as good a result as I can. When you treat in the periorbital region, treat to 70 to 80% of what you would like to get, because the product will still absorb water. If that happens in a cheek, you don't mind, because the cheek can't expand that much. But if it happens in the thin skin of the eyelid, any little expansion is going to appear there. So here's the trick. How do we avoid the late edemas that we see? Never go through the septum of the eye or the orbit, because if you deposit product behind the septum, that patient will swell for life. That product will stay there and not move. And we've done MRIs to show patients who came back a year, 2 years later, and we can't seem to understand. We don't feel any product over here or over here, and yet they keep on swelling. You take a look, and the injector went underneath the orbital septum and deposited the product there. Once you get into underneath the orbital septum, the product just sits there and just keeps on asking for more fluid on occasion. Okay? So
show them where you're aiming.
I'm going to show them. Here's the bottom of the orbit, the bottom of the orbital rim, the supraorbital rim. Here's her eyebrow. I'm going somewhere in between, little pinch. There we go. And we're spinning. Okay?
A little Watusi.
There you go. forgot to wear my grass skirt. You stretch the skin to help you. They'll get this little hair fall, this hair out of the way. Hold it like a dart again. Okay, there we go. We're going to come in at a steeper angle when I find that little hole, and then I'm flattening it out. Do you see what I did right away? I changed the angle of approach, and now I'm switching my hand to injection position. We got that? And then I'm gently going to coax it without forcing it. There it goes. It's going to find its happy place. She doesn't even feel the thing, and look where I am already. Okay? Look at the depth of where I am. Do you see where I am? You can almost see the color of the cannula because I'm in the subdermal plane. People say they get in underneath the muscle here, the orbicularis, between orbicularis and septum. But for those of you who've done blepharoplasty, I dare you to try to find that plane. Even when you're dissecting, you always get a little septal tissue on it, or you leave a little bit of orbicularis on it. So it's not an easy plane to find, and it's certainly not a very non-sensitive thing. And what I'm going to do is I'm going to go, and you can see that my level is below the orbital bone, okay?
Below the promontory.
Below the promontory, exactly. You think that this is a dangerous thing to do. You think that this is a difficult thing to do. I promise you this is easier than doing it right here. Okay? It just, because it's near the eye, it makes people a little bit squeamish and worried about it. I'm going to advance again slowly.
You could almost be a chimpanzee and do this, but it's better to have a
Look where I am. I'm already to the medial canthus, and now I'm going to grab the bottom of the syringe over here, and I'm going to start the flow of product ever so gently in a retrograde fashion. Okay?
This is where the trick comes in, is to go easy on the gas.
No typical amount. I've seen people put 2 and 3 cc's in here. It looks good on stage, but I can promise you that patient's coming back in 4 months, and they're going to look like a frog. Okay? They're going to be all swollen. And then it's a little gentle antegrade and retrograde, and we're doing very gentle little injections over here. You see that again. She's doing great. Am I hurting you? 0.
Yeah, it's surprising. Most patients tolerate this very well, and
very,
it's very rare to bruise.
And then here's a little trick that I do.
Watch what he's doing with his smart hand.
Okay.
Pushing that.
You see, I always have my finger here. I'm always making.
Push that cannula down a little bit.
And now I'm going to try to
towards the apex a little bit.
Unhook it. If.
Sorry about that.
Oh my God, can't even. You've really been working out in the gym. What I normally do is I would unhook it, and I have the patient sit up because I don't want to have to try to access that little hole again. I want you to open your eyes and look.
Hold on to this. He's from Montreal. I can get this off here.
Okay. Just don't raise your eyebrows. Just relax. Okay? And what I'm doing is I'm looking to see any little areas that perhaps I need to trade a little more. There's a little bit of a dent over here. Using very small amounts of product. Okay.
It's really important to have your patient sit up like that and to actually blink and have a little animation. And that little bumpiness, because he's in the sweet spot, it's very blendable. So if you just be a little patient, we can do even something else and come back, and that'll just look a little better.
Open your eyes. Okay, we got to get you lined up here so they can see without opening your eyebrows. Just look straight ahead. Okay, and what we see over here, here we go. We can see that we're starting to fill it in. Can I have a marking pen? See, this is what I would have done if she was. You're looking at yourself in the thing.
I'm not looking.
Okay, because then I'm going to have trouble to try to adjust this. Okay, let me have the marking pencil, please.
Oh, marking pencil?
Yeah, I don't want that. Just the white one. Just the white one.
A white one. White one's good there.
So look straight ahead. Just concentrate on looking
that
straight
little
ahead.
tiny brown one there.
Good.
That one's good. Yeah, the little black one there's fine.
Good. We're getting there. Okay, let me look at you. I'm going to block your view, guys. I just want to make sure that I line this up right. I'm looking to see where I need a little more product. Normally I have the cannula sitting in here, but now I'm going to have to re-enter the cannula. There we go. Let me have a little more of the product, please, in the cleanser. Are there any questions about this? Is anybody else in the audience doing infrabrow, as I call it? So that puts it on label when you're...
we've kind of changed from A-frame to infrabrow. So how many are doing orbital hollowing? There's quite a few. Awesome.
Good for you.
Good. Great.
Good for you.
What are the danger zones in that area?
Where do you think? Everything.
Yeah, it's you have to be paying attention.
It's actually a lot less dangerous than it looks because
the vessels
are above. The vessels are above. The danger really is for you to go ahead and to start injecting behind the septum, but that's why I'm cantilevered against the bone over here, okay? And why I'm not forcing the cannula to go where it doesn't want to go. You see where the tip of the cannula is now? I'm trying to get it to that little defect that I had before.
Just that little apex there.
The real danger is just putting in too much product too quickly. So you've got to use very small amounts of product. Okay? Like I said, I would unhook the cannula normally. And I'm going to just massage this very gently. And we're going to see if we can build a little bit of a nice contour over here. Open your eyes. That's my girl. That's my girl. Okay. Look straight over here. Okay, I need it just a little bit more laterally, and I think we'll be done. And there shouldn't be much bruising at all. Can I look at you? Yeah. Okay. So we filled in most of the area over here. I'm going to adjust that last little bit, and we're going to take a look. So that's basically how to do an infrabrow the way that I do it. It's the way that I was actually taught to do it by Stephen Liu. Something similar to that when I was in Australia. And I find that it really, and this, by the way, the result will last how long? Years and years and years. The first one that I did on a patient of mine, it's probably about 4 years now. I haven't had to retreat her. Okay? You know that if you do a tear trough poorly, that you're going to look at that poor tear trough for years unless you do something to correct it. You're doing great, Ellen, by the way. All the patients get ice afterwards.
Probably have to make up some more.
The silk won't swell that much over here because you've already added in what it's looking for.
Silk.
So there shouldn't be a whole bunch of swelling. I know that some people have reported they get silk swelling in the lips. The silk swelling in the lips, again, is if you drive this product into the muscle of the lip, it doesn't like it. These are little delicate products. They like to be in that in-between area.
That's why I left this syringe in here.
Good. Put your chin down. Maybe we can do this while you're just sitting over here. Open your eyes now. Okay.
I'm making a mess, aren't I? I don't want to do that.
So if I wanted to go ahead and soften the crow's feet with a meso mix of filler and toxin or just filler itself, my injection point is usually below over here. I coat under the skin. I use a 27 gauge so that I don't have something sharp that causes bruising over here. And again, palm with my filler because I'm using small amounts, and I coat over the whole area over here, and we just do that. Okay? Can I have a little bit of arnica gel, please? What else did we want to treat on her? It's kind of like 5:45. You guys are still hanging in here. It's unbelievable. Sorry? Temples on her?
No, thanks. How about my left side?
How about her left side, she says. We don't want to treat her left side, do we? No. Why would we want to do that?
I'd like to see you do the left side pulling the jowl back.
Yeah, okay. To see if we can get the same effect.
Well, I just want to see how you do it again.
Sure. Look at me straight on, honey. Oh, we're getting there. Look up. Look up. Yeah, she should have a little toxin to drop down her brow.
Don't get me started with that.
Yeah. You see these little areas? These are you've had toxin put in?
Yes, and you dropped mine.
I dropped her eyebrows down where we heard them hit the floor. She said to me, when she came up and saw me in Montreal, she said to me, I have a very sensitive, I've had people drop the brow. I said, no problem. I said, if you want to do something. She said, yeah, we can do something. I said, I'm going to stay on the top of the hairline over here, and I put in 4 units of Botox, equivalent to 10 units of Dysport, in 1, 2, 3 little 4 injections. And what do you think happened? Oh, yeah. From up here. And I said, okay, you win. You're right. It's going to happen with a physician. That's for sure. Absolutely. So I did that at the same time.
Don't even tell them.
We had everything go sideways
you don't
on
really
us.
Want to know.
You don't really want to know. We did that. She looked good for 2 months, right? For 2 months. Yeah, about that, a month and a half or something like that.
So 2 weeks after my son's wedding.
Yes. We got her through her son's wedding. Thank God. And then about 2 weeks after her son's wedding, she called me and said, I got these bumps that are starting up on my forehead. I said, oh, here we go. I rarely get that type of issue, but if it's somebody you know and it's somebody who's a physician, never say you're a physician when you go to emergency room, and then things will start to happen. Yeah, what's that? What are you giving me?
Blend.
Blend of what? Silk.
1 2 3/4.
Wow.
Silk.
Let's take a look. Well, that's looking much better now.
Yeah.
Huh?
Just got to be.
Yep. She needs just a teeny little bit laterally.
On her lateral
Yep,
side.
that's it. So give me a little cleanser again. I want to see. These things plug up so fast. Here's my cleanser. These things plug up so fast. Can I find that little hole again?
Well,
Yes, I
especially
do.
when you're using a 27 gauge stroke car. Here,
I know. I love to challenge myself.
I use 25.
He gave me 0.2, so I'm at about 0.2 and maybe a little bit, another 0.25 or something. Even that's a little bit much.
Yeah, probably 0.3 total.
Not even.
Yeah, 0.25.
But that's blended, right?
That's blended 1 2 3/4. 3/4 saline and one of silk.
Okay.
And
Let's
we'll
have
do
the
a
stuff
little-
that we used on our jawline for Dr. Lalonde over there and see what we can do jawline-wise. Just pure jawline. I'm not going to fill her cheek, which you can see that she has a little bit of a volume loss in her cheek over here. But we're going to see if just purely, that's a good test for me because I usually, when I do a face, I work from above down. Do you guys do that same thing too? Do you have a tendency to work first in the upper, then the middle, if you're doing a full face, and then the lower? I just got into that habit of doing it that way. So how much of the effect is from the cheek and how much of the effect is from this? So let's look at this alone, see if we get an improvement if we have to augment it. How's that, Don? Would you like that, or do you want me to do her cheek first? No, let's do just purely that, okay?
You want to finish your orbit, or do you want to do...
Her orbit's done on this side.
this side.
Yeah, this side I'll go ahead and do it afterwards. I'm going to do this and the orbit
All right.
on her. We got to do the upper lip because we got to get
Okay.
rid of those lines.
Fine. 30, correct?
You know the whole story already. You can come do it. Give me the cleanser, please. So again, what I'm doing is I'm targeting this area over here. Okay, that's the pre-parotid area. I'm cleaning. I'm making sure we don't get this stuff in her eyes, which it won't happen. I used to use this. I used it all the time. We used to use the 0.02% to do our blepharoplasties, and the sponges would be dripping in it, and we would just coat the face, and the stuff would just pool there, and we clean it, and we got away with it. But every now and then, you can end up with a patient that develops a really intense keratitis. That would be you. For sure that would be you. Somehow I'm going to drop your brows by injecting here. I don't know how, but it's going to happen.
Refine on the 30.
Can you do this with the cannula, or do you need to do it with the needle?
I don't know. I just started doing it with a needle. My old cannula technique was to do this and then to do, like Kent was talking about, a vertical thing, but I didn't think that I was actually getting the little sort of tacking effect of the cohesive product. I thought I was just going ahead and contouring. But this over here, and she only gave me 0.2, so I'll need another 0.2 to equal the other side.
You're using refine there?
Yeah, this is going to be refined. I want to make sure that you guys can see this.
A little bit more
So she's
refined.
good. Can you see? I'm just taking a look. Yes. So we're going to let it fall back into the needle. I'm staying superficial, lifting, and I'm tacking. Don, can you see that? Okay, buddy. And I'm attacking with 0.05. Look at I'm even looking at my plunger, which I shouldn't be doing, but there it is, 0.05. That's all you need. Just a little tack like that. There's my little bump. We're going to go ahead and do the next thing like that. We're going to do this a little bit quicker because yeah, just below it. It's like you're putting in, like you're tacking a carpet.
It's midnight. Oh, no, it's 6 o'clock.
I've injected till midnight, so don't worry. I've actually been injecting a patient while they've closed up the place and they're carrying the table out, and I'm still going at it.
We've done that a few times in Toronto and Montreal.
Yeah. Done some crazy things. I need a little bit more. I only use 0.2, so here we go. Same thing, size of the needle on that, 30? Thank you so much. Lorraine, you're great.
Refine. Straight up.
Yeah, and I've been using this in my office with Voluma and with Volift, which
Same
you
thing.
do
And
love.
Vollift
is really nice for here, which is going to be, what's going to be called here?
Volure.
Volure. Which, yes.
That's a good answer.
Depends on the structure, but like in her, I would use Volift. Because she's pretty petite and got fine structure. You're just trying to create contour and a little shape. You're not trying to create any projection.
Don't use the D word, but I'll listen to what you're saying. If you say the D word, I won't listen to you. Blending or recon, yeah. Yeah, because if you get used to using the D word, you'll say it in front of the patient with your nurse, and then you'll really get blasted. What are you diluting the product for? No, I'm adding in a little extra anesthetic so that you guys, feel more comfortable.
My nurses get their wages deducted if they ever use
the D word. So this was just 0.4. And we're going to take a look now. Okay, let's sit her up. There we go. Let me position your head. Just relax now. I haven't done any work around her mouth yet. Oh yeah, look at it. We're almost there. With a little bit of cheek work over here and a little bit of this, and we're going to get this type of result. Okay, that's what we're after. Remember, she was quite jowly on that side before too. So the question is, will it last? What's the longevity of it? I don't know. I only have about 3 weeks worth of experience, but I got to tell you, the 3 weeks the patients are hugging and kissing you. They're very excited about it. She's looking very good along her jawline over here. We're going to do a little bit of lift to her cheek because we want to get her off the table, and we're going to be finished by 6 o'clock. And that includes...
So you want define?
Define or lift?
Lift. You got lift there? Is that lift? Okay.
This little thing? This little thing? Oh, this here. Oh, what about it?
What do I have? What else do I have?
Oh, yeah, I want to wander there with her, that's for sure. Not is right. You know what happens sometimes is patients will smile. Give me a big smile. Put your head down just a little bit so they're actually getting the camera from over here. So give a smile. They get this flattening over here that they complain about. Do you see that on both sides? That's cannula country, and that's cannula country really in a superficial injection because angular artery is right underneath there.
I want to go sub-Q.
Yeah, so you're really sort of sitting
pattern.
underneath the skin when you want to do that. You're doing good because I'm not bruising you like I've done in the past. You know that. What else did I not do to her? Just about probably... No, I'm talking about when I did it at my office.
And you erased my face with the Vitrace.
Yes. Well, when I erased your face, then we bruised her. That was nice.
If you were going to see in that little area, what product would you use?
I'm sorry?
If you're going to see in that little area.
Refine.
Yeah, I would use Belotero Balance, Refine, or I would use Volbella.
You could use
something
Lift. You could use. You could use Silk there as well. Silk works really well.
And the question is, have I ever injected lip lines directly? The answer is yes.
She said, do you still?
Oh yeah.
And I still do it. And you know what I do that with? I do it with Balance, which is really great, the Belotero product, because you can do, and we'll do that tomorrow maybe on a patient. We'll do that, and I'll show you the blanching technique. Have you seen that technique before? Where you inject into the epidermal junction almost. You're very superficial, and the skin turns completely white, but you blanch out those little lines over there. So what I do is I do this technique. You can see the half of the lip that we've done already. There's no anesthetic left over there now. It's been already an hour that she's been sitting here. Give me the pucker. So she's getting a couple of little lines, but not much. We've sort of allowed it to glide and slide now. But if she had some very deep lines afterwards, yes, I would do that transverse thing and then chase a line or two, for sure. Small stick.
Lift, right?
Yeah, this is Resty Lift, I believe, right?
Mm-hmm.
Correct.
Yes, so I'm going to try to make you somewhat symmetrical. Am I hurting you? A little bit?
Yeah, all right.
Okay. Slow injection. You can fire this stuff in, but we just don't want to do that. When I get to the area like this, that's a little bit depressed and it's below the level of the bone, I cannot go in deep. So it's a half-depth injection. See where my needle is? Then I lift and I fill.
And you could use cannulas here as well.
Absolutely.
Works well.
See, but look how that product even... Okay, this is a product that's Resty Lift. Resty Lift is supposed to be all G' and no cohesivity. So tell me why that it's all sticking together like this. Because it depends on which tissue you're putting it into. If I was putting it down on bone and I was in an area that had a pre-peritoneal space, yeah, the product is not going to be able to stay together very well. But if I'm putting it into fat where it's limited, then the product stays together and still has a G' to lift. So it's not so much the cohesivity, it's understanding of how the product's going to work for you in the areas that you're injecting it. Okay? You're doing great. So we would have used Total on her.
And tomorrow we're using Allergan products.
Yep.
So
Whole day. Here we go. What else you got? Throw something at me.
what do you want? What are you trying to do?
I don't know. I want to try to take a look and see. This positioning is really crazy here. Look up into the camera over there. Let me just take a look. How we doing? That's right. Keep reminding me, Don. That's a boy. Yeah, forget that, but you got to remind me that too. What do you? Have you got any define?
Yes.
So give me the define that you have open. We'll
Fine,
finish
you
off
want
that,
with the-
and we'll do the upper lid. Oh, excuse me. We'll do the infrabrow, and then we'll call it a day.
No,
for,
how about my upper lip?
What?
and the no, we'll leave that.
You want infrabrow? You want infrabrow now?
What do you have?
Well, whatever you want. We got it all.
Well, what's open?
The refine and
Caviar or what?
Don't
Give me the
distract
stuff for
him.
the upper lip. So that's going to be refine
Yes.
on a 27 gauge
Yes.
cannula. Okay.
Here's the cannula right here. I got the cannula in my hand.
Okay.
And I'll try not to screw it on so
If
tight.
you're using Botox on the upper lip, how many units are you going to use?
I got a 27 gauge cannula right here.
Oh, but did you poke the hole?
So you're using
No.
a total of 2 units? So that's what I use.
30.
If I'm using Dysport, then I'm using, let's say, 5 units.
That's the 27.
Yeah.
5 Dysport units, okay? That's for sure.
That's all
So
right.
whatever,
Just
if I'm
put it
doing
on there
crow's
and cap
feet,
it,
what would
that's
you
all.
put into crow's feet normally?
cap it.
There we go.
Okay.
333, so 9 units. If that's what you're used to using, and 9 units of Botox units or Xeomin units, or if you're used to using 25 units of Dysport, add that into your
He's
filler
coming.
and do
He's
it.
coming. I'll get his attention. He's
I'll eventually
Just
pay
sidetracked.
attention.
Forget me.
I won't forget you. Don't worry about it. Small little stick.
I wonder you're 3 hours behind in your clinic all the time.
Always, because I'm always talking. It's the worst. Here we go. Let's take that thing out.
Oh,
Now we got to find that little hole, and then we got to flatten it out. We gotta
and
get-
so notice he puts that cannula, the syringe right flat, and so he's parallel now to where he wants to go.
Back into the palm we go. See where we are over here? You can see it.
You can actually see on the camera better than we can see up here.
Yeah. That's not me. That's you. What do you have on your lip over there? It's a little dark spot. It's not me giving you
A little pigment on the driver's side.
I know it's sensitive because I'm going a little faster. I'll slow it down for you, okay? Here's a little septum, okay? I'm not going to push my
These are
way.
these little speed bumps that occur in lips. There's a little speed bump right there. So it's just like breaking up the little septi and honeycombs.
Remember that little V that we had over there, that little, what we call the Knowles triangle, which I call the female upper lateral lip triangle, the full triangle, which is this thing right here. You see that? This one over here? I'm going to try to buttress across it, just a little bit of product here,
And
very gentle.
as you hinted at, men don't get that.
Yeah.
It's
So I
structural change.
checked the gay men in my practice to see if they had it, because the way, especially the ones that had a more feminine way of expressing
No,
themselves,
they don't have
they
it.
don't have it.
No.
So what does it represent? It represents a loss of structure in the upper lip, which women get because they don't have those deep hair follicles that we do that are acting like
Rebars.
pylons. Exactly. And because we shave all the time. So girls, there's an advantage to us having hair on the upper lip. We don't get that little thing. But I told you there's 2 things that women have above their neck that men don't have. One's that triangle, and the other one is,
The brain.
you got it, higher intelligence.
That's very good.
Very good. Okay, I'm going to come up over here a little bit. Again, for my depth, I'm subdermal, okay? This is what we call subdermal sheeting.
It's a little bit sensitive.
Yeah, but you can definitely chase it up over here, and you can do a little bit. See, there's a little septum over there. Put a little bit of product in, back off. There, just pop through, okay?
Here's where you have to really let off the gas. You want really small amounts of product, tiny bits.
Okay. Yeah, don't force anything. I just don't like to force cannulas. I like to just do it gently. And now, guys, we got to go south. Changing the direction through the same hole can be a little tricky. You have to pull out the cannula almost to its complete length and then flip it down. You're going to feel a pop over here. There it goes. Okay? And I'm going to fill in this little bottom part right over here and there. Yeah, I'm sorry. You know, this is the one that was a little sensitive on the other side. There we go.
See, it's interesting. The video is always exaggerated because he's being very, very gentle here.
Sort of.
Well,
we know each other for a while now, so she knows that Here we go. We're almost done, Ellen, okay? I'm sorry. If I drive it up a little bit too superficial and scrape the undersurface of the dermis, she'll let me know. That's the little pain that she feels over there, so I got to make sure my cannula doesn't go down too deep. There we go. Okay? Last little bit.
She never had so much fun.
Yeah, last little
Doing
bit.
great,
I'm just
Ellen.
going for broke here, that's why. Okay? You all right?
Mm-hmm.
You sure?
Mm-hmm.
So I've used the total. This is Refine, which I could have used Volift or Volure. I could have used Ultra for this. And this is 0.3.
0.35.
Can I have the arnica gel, please?
Arnica gel or ultrasound gel?
Thank you. Whoa, that's a lot. That's a big blurch. That's why I'm using such a small amount. Especially in patients who have a cant on their upper lip. Patients who already have their teeth projecting forward like that, you're going to make them look simian. You're going to make them look too much like a monkey. So you've got to be careful about that.
Still a 27 gauge.
Yep.
Yeah, you could. I use Volbella there quite a bit. Absolutely.
Where was that? Where?
No, it's not a question of even the hydrophilicity. It's just a question of the fact that it's just a thinner product. And in a patient that I'm really just trying to, I would use it. It depends on what I have open. But I'm saying, it's a palette of colors, and there's different shades. I won't say how many to gray, right? But there certainly are different shades to gray. You have a little bump there. I'm gonna take care of it. Okay.
Yes, I'm fine.
That's good.
Some gel.
Won't be a big bruise. Won't allow it. I'm sorry. Say that again. Sure, I could. You saw that I could go right into the lip with the cannula over here.
Here, I'll play with
Well,
that.
take a look at her over here. You can see now.
I'll play with this a little.
Yeah, thanks. Just hold a little pressure there. You can see that her upper lip, the lines are starting to efface already again too. Part of that is, is lidocaine effect because she can't contract as much. Part of that is what we were doing with releasing. Okay. But yeah, you can use Volbella. You can line the lip over there. I'd use that same entry point sometimes to turn it the opposite way and fill in a submalar area. It's however you feel. But the idea here is really it's not volume like we were talking about. It's structure. That's what you're trying to do. That's better. Ken's doing a good job. Okay. We're going to fix that little thing. Yeah, it's almost gone. Any other questions? We'll finish her off with the upper eyelid and everything, and I'll get her all done.
Pretty well. You feel it on this side?
So the question is, when I use the Mesomix, I use it over here on the bottom, and sometimes I do, but there's really no purpose to doing it because the muscles are deeper, the ones that you want to affect. So the Mesomix that I use is going to be here for crow's. It's going to be for neck, and it's going to be for the perioral region over here. You know, there was an article written a long time ago, quite a few years ago, about mixing the two products, the toxin and the filler, and then injecting it into the dermis over here. But I didn't understand the purpose of that because you're injecting the toxin into the dermis, and you want the product to get deep into the corrugator. It has to get through everything else, the fibers of the frontalis and everything. It just didn't make sense. But if we target the same area, then we can absolutely try to combine them, but you don't have to. If you're more comfortable using the separate injections, go right ahead. No question, I agree. If in the crow's foot area, absolutely. Do I do that for lower lid? Never. Because with the lower lid, what happens is that you're using a hydrophilic product that's drawing in water and you're knocking out the lymphatics at the same time. Even when I do patients' tear troughs, I will not treat the lower lid at the same time with a small bleb of toxin, what we usually do in the mid-pupillary line. I wait on that. I wait for them to get through the filler session, and then I do the toxin, or vice versa. But you're very right. If you do it both at the same time, you'll cause a problem here. I don't do the toxin and filler combination, even if it's separate or in the same syringe, if a patient has a festoon. Because if they have any type of fluid retention over here, it's telling me the lymphatics are already taxed to the most. And if I go ahead and add in something that's going to draw in some more fluid, it makes it worse. Some people say, well, why don't you put the filler next to it and have it draw off the fluid from the festoon? That's never worked for me. It just makes it worse. And when we talk about... Hi. You doing a selfie? Mm-hmm. Oh, okay. Hold this just for me for a second, Al. Thanks. When you're doing periorbital, remember I said to undertreat? People say, why do you undertreat in the orbit? Because the fact that it absorbs fluid and then it will do the rest of the work for you. Now, that's the most difficult thing to do. Even as a surgeon, the most difficult thing to do, and Don will tell you this, is to sit on your hands in the operating room, meaning you don't do anything. You get into bleeding and you want to do something about it. What we do is we pack and we wait. And that's a killer because we're sitting there 5 minutes waiting so we can remove the pack and then start to see where the bleeding is going from. It's hard to do that. The hard thing as an injector is to let a patient leave your office with them still wanting a little bit of filler here because it looks like they need it. You cannot inject that last little amount. Please don't. Because they will swell 4 or 5 months down the road. That patient will go and have a glass of wine. She'll go and cry at a movie. Something will happen that she'll sleep on her face. She'll get fluid retention at that point, and the product is waiting for the fluid. Even though we've already hydrated it, it will take in that little extra bit of fluid. So people say, well, that's a big deal. So if they come back a little swollen, use hyaluronidase, and you can melt out what's going on in the tear troughs. But what are you doing when you melt out the product? You're not making it disappear. You're changing hyaluronic acid into water. That's what happens when you add in hyaluronidase. You're already taxed because they're swollen. They're already taxed with their lymphatics. Their lymphatics are clogged. And now you're adding more water into it by adding in hyaluronidase liquid and then turning what's there into more liquid. They get festooned. And then you have to wait a week for that festooning to go away with ice compresses. And they'll drive you crazy. So when it comes to this area, I don't like to use hyaluronidase if I can avoid it because it sets up a vicious cycle. So the best thing to do is to undertreat and work your way up, then having a perfect result when they leave your office, and then having 1 or 2 or 3 out of 10 that come back that are too swollen. The final word that I'll say on that, because it's already 6:12, guys, come on. The final word that I'll say on that is that Kent was alluding to, and we're going to do this tomorrow. We're going to do some tear trough work tomorrow. Understanding the anatomy of the tear trough is what's changed the way that I do tear troughs, because they're the easiest area to do poorly. Understanding that the muscle, the orbicularis muscle, is not shaped like a Gucci glasses. It's shaped like the Ray-Bans. They're shaped like aviators. So the muscle comes down way lower laterally over here. And we've even seen muscle when we do facelifts that starts to come through several centimeters out towards the sideburn. That muscle can be very wide and extensive. That muscle is a sphincter muscle. It contracts. It doesn't do this. It does this. Okay? So in order to do that, it's attached medially above and below the medial canthus to the bone. Like the temporalis, it's anchored here. There's very little SUF, very few fat fibers underneath it over here. In fact, the SUF only starts 3 or 4 millimeters below it, and at that actual orbital rim where the muscle is, it's adherent. It bleeds like stink when we try to lift it. The rest of the muscle, except for a midline raphe over here, is gliding over the SUF and the roof, the suborbicularis oculi fat and the retroorbicularis oculi fat. They're acting as a glide plane for the muscle to do this. So when you squint, you pull your eyebrow down and in. If you go ahead and inject on the orbital rim, which we said you can because the infraorbital artery is lower, it's 5 to 8 millimeters lower. So if you put your little product on the tear trough to revolumize a tear trough, not deformity, but a tear trough, period, if you put a little volume in there, you're not going on the bone. You're actually going, not pre-periosteal to speak, you're intramuscular. If you dissect out these injections over here, they're actually in the muscle. Now, what's the problem with that? The problem with that is if you put in all your fill over here into that area, what happens over a period of weeks and months is the patient is squinting and blinking 20,000 times a day. And they're constantly contracting and kicking your product around. So it's like squeezing a tube of toothpaste from the middle. Where does the product going to go? It can't go this way because it's all tethered down. It's only one place that it can go, and it will accumulate as a ball right here. And that's why we see those bluish Tyndall balls that occur 3-4 months later, because that's an accumulation of product, no matter what you use, that's been squeezed constantly by the muscles. So when I saw that and I tried to figure out why is it always happening here and why is there that 4-month delay, I said, I got to go back into the anatomy lab and see how to do this differently. So now I realize that when I attack the tear trough, what I do is I put very little product on bone, just a teeny little amount. Like I'm talking about 0.02 per little bolus, 2 or 3 boluses, or I do like Kent does. We put a little bolus and we milk it a little bit. And then the rest of my treatment is above the muscle, like I do in the infrabrow. I go under the dermis over here, and there I use a 30-gauge cannula, as I will tomorrow, to coat over that area. So what I've done is I've put product over the muscle and very little product at the bottom of the muscle, which is supposed to be under, but it's not under, it's in. And I'm trying to leave the muscle alone. That's what we do in blepharoplasties now. We don't attack the muscle anymore. It's called the middle lamella. We leave it alone. We do something to the outside, the skin, whether it's skin tightening, whether it's a pinch blepharoplasty, whether it's laser treatment to contract it. And then we do our fat work behind, leaving the septum and the muscle alone. This is the way to treat it with fillers as well. Do it in a 2-layer approach. You'll never need more than 0.15, 0.2 maximum to do a full tear trough. It's a small amount of product. What you're doing is you're putting the mustard on both sides of the inside of the bread, but you're leaving the bologna alone on the middle. Patients won't swell, and they won't have that problem 4 months later because there's no product to kick around. And I started doing it that way. It has made a huge difference in my approach to tear troughs. And I want to show you that tomorrow because I think you guys think it's a difficult thing. It's easy. Add to that the fact that we were seeing what Kent was talking about, of a tear trough darkness being as a result of shadowing, pigmentation, and visibility of veins behind it that are Tyndaling. You can imagine that if you coat a product over the muscle in a very thin coat that's non-Tyndall, you remove the darkness of the lower lids. You take away the shadow, you take away the Tyndall of the vessels, and all that's left is pigment. And for pigment, you guys know what to do, especially the derms. You'll throw the patient on whatever it is, hydroquinone, azelaic acid, whatever you want to use. And so you can improve the look of the lower lid, not only in the contour, but as Ken showed you, in the actual brightness and lightness of it. And that's my final word, and we'll talk again tomorrow.